Athletes and the appropriate management of athletes with cardiovascular condition, including eligibility decisions, are together with the emergency plans in the event of a cardiac arrest in the field of play, the three key strategies to prevent the sudden cardiac death in sport. And we saw in this presentation, we will review very briefly the epidemiology and main causes of sudden cardiac death in sport. And we will focus in the role of the pre-participation cardiac screening, the best and most appropriate methodology for the screening of athletes. And I will review also with you the outcome, the clinical outcome of the Aspetar cardiac screening program. The incidence of sudden cardiac death in sport is ranged from 1 to 4 athletes out of 100,000 per year. But maybe this is underestimated. We do know that there are some sports in which the incidence can be as high as 1 out of 11,000 players. And we saw that black athletes and also male are at higher risk of sudden cardiac death. But the relevant question is, do really athletes have a higher risk of sudden cardiac death than non-athletes? And the answer is yes. Studies conducted in Italy, France, and in the States have demonstrated that the athletic population have 3 to 4-fold greater risk of sudden cardiac death. Sudden cardiac death, non-traumatic sudden cardiac death, occurs always in athletes with an underlying cardiac condition predisposing to life-threatening arrhythmias. The sport participation is not per se the cause of sudden death in these athletes. It's just the trigger for these ventricular arrhythmias in players with an underlying cardiac condition. In this setting, the cardiac arrest can be the first and only manifestation of the disease. This is why it's very important, despite having in place a good pre-participation screening program, also to implement emergency plans in all the sport venues in the event of a cardiac arrest of these players. Look at these figures. This is the prevalence of the diseases associated with sudden cardiac death in sport. Maybe 3 to 7 out of 1,000 players may have a cardiac condition associated with sudden cardiac death. So how can we recognize those players that may have a cardiac condition associated with sudden cardiac death? This is the role of the pre-participation cardiac screening. But so far there is no consensus on how best screen athletes to recognize those with an underlying cardiac condition that may predispose them to a cardiac arrest. The basic cardiac screening advocated by the American Heart Association is based only in the history and physical examination. The history is very important. Family history is very important. We do know that the most common causes of sudden cardiac death in sport are cardiomyopathies, also channel diseases. All these are inherited conditions. They are familial disorders. So it's relevant to recognize athletes that may have a family history with one young relative with cardiac condition or who dies suddenly before the age of 50, because these athletes may also have the same condition. Symptoms. It's very important to recognize athletes that may have a cardiac condition if they present symptoms. Dizziness, shortness of breath, chest pain, syncope during exercise. These are very warning symptoms that may help us to recognize athletes with underlying cardiac condition associated with sudden cardiac death. But unfortunately, up to 80% of the players who die suddenly of cardiac arrest never presented any warning symptoms. So we can't rely on symptoms to pick up athletes with heart conditions. The physical history, the physical examination will always add some value to this model of screening, but overall, the sensitivity of this screening model is very low, and up to 60% of the players with underlying cardiac condition will not be identified if we use the American Heart Association recommendation for screening athletes. The European Society of Cardiology advocates for the addition of the electrocardiogram as an important tool to recognize athletes with cardiovascular condition. And a recent meta-analysis have demonstrated that the ECG is the most efficient technique to recognize athletes with underlying cardiac condition associated with sudden cardiac death. Actually, the sensitivity of the screening program based in ECG can be as high as close to 100%. This is the electrocardiogram of a 26-year-old female basketball player. She's from the States, came to Aspetar for a screening. She was completely asymptomatic, no family history of heart disease or cardiac condition, and the physical examination was normal. But the ECG was very abnormal, demonstrating a T-way inversion in inferior and in lateral leads, highly consistent with a possible cardiomyopathy, and specifically hypertrophic cardiomyopathy, which is the most common cause of sudden cardiac death in athletes. And this is what it was demonstrated later on in the echocardiography and the cardiac MRI that we did in this athlete. Unfortunately, this athlete underwent several times screening in the state following the American Heart Association model that was unable to recognize the cardiomyopathy. This is the Italian experience from which the European Society of Cardiology took the idea of including the electrocardiogram as a very important tool in the screening of athletes. In Italy, the screening of athletes, including an electrocardiogram, is mandatory since 1979. During 25 years' experience, the incidence of sudden cardiac death in athletes in Italy dropped from 3.6 to 0.4 just with the implementation of this screening program. That means 90% reduction in the incidence of sudden cardiac death in athletes. This is the most important evidence regarding the role in the reduction of incidence of sudden cardiac death in a sport with a screening program, including physical examination, history, and electrocardiogram. And why the electrocardiogram is so powerful to pick up athletes with underlying cardiac condition? We saw that the electrocardiogram is abnormal in 90% of athletes with cardiomyopathies that are the most common causes of sudden cardiac death, but also is abnormal in most of the ion channel diseases. These are arrhythmic disorders. In both cases, we can pick up athletes, yes, we can identify them, yes, because they present abnormalities in the electrocardiogram. Let's say that we are around 1,000 people in this room. The prevalence of hypertrophic cardiomyopathy, which is the leading cause of sudden death in sport, is 1 out of 500. The complete phenotype of the disease is demonstrated in 1 out of 500 people. That means that 2 of us have hypertrophic cardiomyopathy. But 1 out of 200, up to 5 people in this room, may demonstrate an abnormal ECG as a result of an incomplete penetrance of the disease. And this is the same prevalence that we see in athletes. Some international governing bodies, such as FIFA, recommend the inclusion of an echocardiography as a routine in the performance of the the screening of athletes. Still, this is not recommended by the medical societies, but we have to admit that may add some value to the outcome of these screenings, especially because one of the also very important conditions associated with sudden cardiac death, anomalous coronary arteries, that if you see here, up to 70% of the cases of sudden cardiac death in athletes are due to this abnormality, can be picked up with an echocardiogram if this is performed by a very experienced technician or cardiologist in athletes without any other symptoms. Unfortunately, in this setting, the electrocardiography alone is not powerful enough to help us in pick up this condition. So, what is the experience and what are the learning points of the Aspetar cardiac screening program? So far, we performed around more than 11,000 cardiac screening, but for the purpose of this presentation, I'm going to present to you only the data from the last more than 4,000 screening, around 3,000 athletes. And I'm going to take only this data because these are the athletes that we did the screening using the new refined criteria that my colleague already explained to you. So with the new refined criteria and a more comprehensive echocardiographic protocol, which are the outcome of the cardiac screening program that we do in Aspetar. Our athletes were always screened following the ECG screening principles: history, physical examination, and ECG. But we also add an echocardiography, not only when clinically indicated, but also in a systematic group of athletes that when the federation requested, for example, in football players, where FIFA always requests the echocardiography. That accounts for around 35% of this population. Further investigation, like a Holter or a cardiac MRI exercise test, were done only when clinically indicated, always in a timely manner, allowing that players coming from abroad just for cardiac screening can complete all the evaluation in the first 24 hours. Well, 5.7% of this population had a significant cardiac condition. From this group, 5%, the cardiac condition was not considered to be associated with sudden cardiac death, but these players are currently under follow-up. All return to play, all are playing, but under cardiology follow-up. Most of them have valve abnormalities or very, very abnormal electrocardiogram without demonstrating the complete phenotype of one cardiomyopathy. We do know in our experience that following these athletes, with the time they can demonstrate the phenotype and they maybe need to be disqualified in the future. A number of athletes, 22, accounting for 0.7% of this population, had a cardiac condition associated with sudden cardiac death. Appropriate management of this athlete doesn't mean that all of them will need to be non-eligible. And actually, we have 3 players that were able to return to play with appropriate management, while 19 of these players were considered non-eligible. And here you have something very important for us, which is the prevalence of cardiac condition associated with sudden cardiac death in this population. The most common causes are cardiomyopathies. The most common of them, hypertrophic cardiomyopathy. But look at these figures. 80% of this population had an abnormal coronary artery implantation. 14% abnormal aortic root or stent in aorta. These 2 pathologies are mostly identified through the echocardiography. That means that if we don't do the echocardiography as a routine in 33% of this population, we should have missed most of them. So we think that probably the echocardiography, in addition to the ECG, should be considered also as a part of the screening. And currently, our new protocol includes an echocardiography almost in the first screening in every single athlete coming to Aspetar. The prevalence of sudden cardiac condition associated with sudden cardiac death in our population is 1 out of 134. And that means this is the number of athletes that may be at risk of sudden cardiac death. In summary, the incidence of sudden cardiac death in sport may be not to be very high, but the prevalence of diseases associated with sudden cardiac death in our population is really relevant, and 1 out of 134 athletes may be at risk of sudden cardiac death. Pre-participation cardiac screening based in ECG is effective to reduce the incidence of sudden cardiac death, but when possible, we think that the addition of an echocardiography, ideally in the first screening, should be considered. A number of athletes have a cardiac condition that require a specialist follow-up by a trained sport cardiologist to ensure safe competition and to prevent disqualification when not necessary. And finally, national and international registers are necessary to provide a better epidemiological and etiological approach to sudden cardiac death in the GCC region. Thank you very much.